Welcome to the EAU podcast series, Present and Future of Diagnostics in Prostate Cancer. On this third episode, we are joined by Associate Professor Paweł Rajwa and Professor Scott Eggener. Together, they will discuss why Gleason score 6 prostate cancer should be renamed, exploring the rationale behind this change, its potential impact on clinical practice, and how it could reshape the management and diagnosis of prostate cancer. Join us as we embark on this informative journey.
Welcome everyone to the EAU podcast on renaming Gleason score 6. My name is Paweł Rajwa. I am fellow at the University College London and associate professor at the Center of Postgraduate Medical Education in Warsaw. It's my great honor to have today Professor Scott Eggener from the University of Chicago. Hello, Professor.
Hi, Dr. Rajwa. I'm Scott Eggener at the University of Chicago, and I'm super excited that you're providing this forum to have this important and hopefully lively discussion.
Again, thank you very much that you participate in our podcast. Today we will talk about one of the, I think, hottest topic in urology, which is renaming Gleason score 6 prostate cancer. So could you explain why there is an interest in renaming Gleason score 6 prostate cancer, and what the main concerns are with its current naming?
Yeah, there's a short answer and a very long answer. The short answer is that myself and many others feel that the hypothesis is that by renaming grade group 1 prostate cancer, there will be much more net benefit than net harm, and that it's an important public health issue, and we need to strongly consider it, have healthy conversations amongst all the important medical specialties and patient stakeholders and public policy folks. The long-winded answer is there's no evidence that grade group 1 can cause symptoms, extend beyond the prostate, travel elsewhere, and until someone proves otherwise, I'm not aware of any person in human history who's died from having only pure grade group 1 prostate cancer without higher grade elements. And I think we can minimize unnecessary overdetection and overtreatment by making a name change while still maintaining our goal of curing people of prostate cancer. And an ancillary benefit might be that more men will be screened worldwide and reap the benefits of timely diagnosis and treatment.
Okay, thank you very much. So is it truly like non-lethal, I would say? And what about patients who have PSA over 10? You do the biopsy, it's Gleason score 6 and PSA of 17. You can also tell the man you don't have a cancer and you don't need to be followed up. What do you think about it?
Yeah, it's a great point. Now let me pummel you with some data. So prostatectomy specimens, we did a study with another university where there were 2,500 men with only grade group 1 after prostatectomy. Evidence of extracapsular extension was 0.2%. Not a single man had lymph node metastasis or seminal vesicle invasion. A separate study of 5 centers where 11,000 men had grade group 1 at prostatectomy. And we know they've had it for years or even decades. And at 15 years follow-up, there wasn't a single man who had a metastasis or death from prostate cancer. So I'm absolutely convinced that if you only have grade group 1, it's a benign entity. If you think of cancer definition as being the capability of metastasizing. Now, to directly address your point, our goal as urologists is to identify men with higher grade cancers. If someone has a really high PSA, a high PSA density, biomarkers that are concerning, an MRI that's concerning, and you think there may be undiagnosed higher grade disease, we have a lot of tools available to us to find it. And I'm hopeful and confident that in nearly all men, we can find it in a timely fashion when and if needed.
Thank you very much. Actually, I am just thinking right now, do you believe that renaming Gleason score 6 would improve the adoption of, I would say, the rates of active surveillance, or the other way around? That if you were to rename it as non-cancer, what about active surveillance?
I think backing up a little bit further, that if we were successful doing it, screening rates would go up, because in every guideline, there's understandable concern on the number needed to screen, number needed to treat to save a life. And if you minimize the harms of screening and diagnosis and treatment, it becomes a lot more attractive to screen people on a population level. Now, if the name was changed, frankly, I don't care what the new name is. We're doing some research on what names are attractive. It just shouldn't have that terrible C word, and it should be some form of a precancer or something we monitor or follow, like the millions of other men that we've all seen with high-grade PIN, ASAP, a negative biopsy, but they had a PIRADS 5 lesion and a high PSA, and you're concerned there's something else in there. I do agree with you. One of my concerns is that patients wouldn't be as compliant and follow up. But all those patients I just mentioned with negative biopsy, high-grade PIN, ASAP, we know a subset of them have higher grade lesions, and I've never heard a urologist worry about them following up. You give them advice on when to follow up. You're either screening them or doing surveillance, whatever your terminology is. And I'm optimistic that this would be a positive move.
I fully agree, and I think this is a direction that probably we should go with. This is also from the practice. And in your opinion, how does labeling Gleason score 6 as cancer affects patients' psychological well-being and treatment decisions? This is something that also I face in daily practice.
It's totally understandable from a patient perspective. You know, in our country, we've had a war on cancer. Most people who are diagnosed with prostate cancer know people who have died of cancer. They're not expected to have the knowledge that all quote unquote cancers have different risks to them. And so the way we've combated that is great data on surveillance. I've also combated that, as many others. Prior to a biopsy, I tell people, if you're diagnosed with this entity, it's a small, wimpy, quote unquote cancer, and we're just going to monitor it. Now, in our country, we've made a lot of progress where it appears 60% of people diagnosed with grade group 1 are on surveillance, but I find it very depressing that there's still 40% getting treated. We have pockets in our country where surveillance rates are 90%. There are countries that have surveillance rates over 90%, but disturbingly, there's also a lot of countries that have surveillance rates of less than 10%. So I think there's a lot of work to do on many, many fronts. One other thing to answer your question, it's really, really depressing when you look at data that people diagnosed with grade group 1 in the United States and in Sweden have a higher likelihood of depression and suicide. And then I know a number of patients, and one has even written about it, where they lost their life insurance. So paradoxically, they have a better long-term survival than the general population without cancer because they were healthy enough to be screened. They have grade group 1. They lost their life insurance for this entity that is never going to cause them a problem.
Personally, I have also this feeling that renaming Gleason score 6 as non-cancer would probably improve general the outcomes of treatment and the life of patients with prostate cancer. It's something that definitely changed it. And what do you think about impact of renaming on screening policies? Would it change it? How do you see how it would impact the screening across the globe in United States?
I would hope it would make it a lot more attractive. Most urologists, not all, are advocates of smart screening. However, we have a massive problem outside of urology with primary care doctors, with public policy, with epidemiologists, and I understand some of their hesitation. We don't have to go into it now, but there's appropriate pushback on screening because you're way more likely to be harmed by screening than helped. And if we can get rid of a big chunk of the downstream bad effects and focus on the ratio of benefits, hopefully it becomes a lot more common. In our country, even amongst healthy men, depending on what study you're looking at, 30 to 50% of men undergo screening. We had a huge drop in cancer-specific mortality, but that's with only part of the population getting screened. Imagine if every healthy man who chooses to undergoes, smart, safe, reasonable screening.
5 years ago, I thought that probably active surveillance is the answer. I was like, yeah, we should detect that, like do targeted systematic biopsies and detect everything and then do active surveillance. But when I see what's going around, maybe better to do just targeted biopsies and don't detect what is all over there. What is your opinion on this?
I agree with you, and I have two main points to complement that. Number one is the very attractive elements of biomarkers and MRIs are that they don't diagnose as much grade group 1. There's fewer men diagnosed, and that's attractive. How is it any different than if you are diagnosed with it? Maybe it should have a different name. And the second thing is, I have said an infinite number of times to patients with grade group 1, I wish I could undiagnose you. I wish you never knew about this, because all it has done is cause you some suffering, more intense follow-up, concern, anxiety. Some guys go race off and get treatment, all for something that is highly, highly unlikely to ever be a problem for them.
And what are the main arguments from those opposed to renaming Gleason score 6, and how do you respond to their concerns and comments?
I have a slide when I give talks on this that have about 8 to 10 of the counter arguments. I'll mention some of the common ones. Number one, the pathologists say, well, by the rules of what cancer is, we have to call this cancer. There are other examples outside of prostate cancer where there have been modifications. Number two, I hear it has some genomic and molecular alterations that are similar to higher grade cancers. That is true. Guess what? High grade PIN, ASAP, and sometimes benign prostate can share those same alterations with high grade cancer. We don't want to call those cancer. Next is compliance of patients. I share some of those concerns. We need to do a good job of educating patients that if the name change did occur, that they still need monitoring and follow-up. Another one are the global implications of it. I think it's a luxury for people in your country where you practice and where I practice that this may be a positive change. I spend some time overseas with service-related activities, most recently in East Africa. The landscape is very different, and I do think, based on access to care and for a variety of reasons that you already know, maybe there needs to be other considerations there. So those are some of the main ones. There's many others, but those are the key ones.
And in your opinion, you would still rename it, considering these arguments?
You know, I started this journey about 10 years ago, and I say quite seriously that I would only mention it to close friends after a drink or two of alcohol, because it was not a very popular topic. Since that time, as I've spent more time in this space, seen thousands of more patients, done more research on it, seen the research of others, I am absolutely convinced, acknowledging I may have bias and blind spots, that I want to shout it from the rooftops, and I'm convinced it would be a positive move for public health in most, industrialized countries.
I'm much less experienced than you, and sometimes it's hard to me if I see a patient 75 and he was treated for low-risk prostate cancer and he's incontinent, and I see then the feeling that it actually changed his quality of life without any impact on survival, actually.
Yeah, and break it down to the simplistic thing. First, do no harm. There are literally millions, if not tens of millions of men around this planet that have experienced temporary or lifelong harm diagnosing and treating something that was never destined or extremely unlikely to cause them problems.
And if we would now rename Gleason grade group 1 disease today, what would be the next step? Education patients in urologist education and broader medical community about the change, how it would look like?
Yeah, it's first of all, the name has to be a collective conversation. And this isn't just a urology thing. There are multiple other important stakeholders at the table. And it's a process. Nothing happens overnight, particularly in medicine. But there are blueprints on how this has been done in other cancers that have lost the cancer label. And it's never been as dramatic as in a highly prevalent disease like prostate cancer, but it's happened in thyroid, bladder, kidney. There's talk of doing it in breast as well. And it needs to be an education and awareness campaign amongst physicians, patients, policy people, family members, but it's really no different than what was done with surveillance. I mean, I remember back where the concept of active surveillance was considered a crime against humanity by some people. And over time, slowly or appropriately, depending on who you ask, it's become commonplace. And something with a nomenclature change would be no different.
Actually, I would like to ask you why it's not happening.
Old habits die hard in many industries, particularly in medicine. I do think there are some legitimate concerns that are important conversations that need to be hashed out and flushed out. Taking care of patients with prostate cancer is very common. It can be very lucrative. And I do think there are just some people that are older and set in their ways that are resistant to the change. And one of the pieces of survey data we have, the people that were most enthusiastic about a name change within any specialty were urologists who were younger, who had oncology training and saw a lot of patients with prostate cancer. The ones that were most resistant were the pathologists who never see the patients and older urologists who, for a variety of reasons, may not be comfortable with the change.
Yeah, or who treated thousands of patients like this. Thank you very much for your time and for the podcast. I feel it very educational. Thank you very much, Professor.
Thank you very much. Yeah, I really appreciate the forum, the questions, and looking forward to the online comments or the direct comments at me, or people agreeing or wanting to punch me in the face. That's part of the scientific debate.
Thank you very much.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.